and then we're going to go from anatomic areas from hip to femur to knee, lower leg, foot and ankle, and then conclude. And our goal is by the end for us to have had a general review of the causes of a pediatric limp or a painful lower extremity in the child, and how from an imaging perspective we could work those up. So some of the things that we would consider are the child's age, the location of the pain, and sometimes this is difficult. They're not always able to tell us where the pain is, depending on their age. And then, in general, we try to make an evaluation of whether that child has had trauma, known trauma, and whether we think that the child could have a possible infection. Because depending on our concern on the spectrum between trauma and infection, our approach will be a little bit different. We're going to start with cases. So the first case is in the hip. This is a case of a 7-year-old girl who's had hip pain for 1 week in her left hip. Oftentimes we have an initial imaging workup. Besides our clinical exam, potentially some labs, physical examination, and history, it's very prudent and very reasonable to start with radiographs of the affected area. In this case, we can see that there are 2 views of the pelvis and hips. We have AP views and frog leg views. In many cases, the radiographs are not able to give us much information. However, if there was a fracture or a large tumor, especially if it was erosive, we would be able to see it. In this case, some very astute radiologists may have been able to pick up some findings, but in many cases, most of us would say that this is not instructive. This child ends up getting an MRI, and on the MRI, we can see a couple of findings. So just for everyone, some of you may be very familiar with MRI, and some of you may not be. So we're going to go very slowly and basically here. If you look in this left column, we have T2 weighted images. T2 weighted images, recall, show you fluid. They're very sensitive for fluid. All the way on the right, we have T1 weighted images. Recall that T1 weighted images are very good for showing us anatomy, and the fat is bright. And in the middle, we have contrast enhanced images. So this will show us areas of inflammation. Now, before I tell you what we see, I want you to try to decide yourself if you think that there's any abnormality on these images. Is there any asymmetry that you see? So I'll give you a second. What we noticed was, when you look at the fluid-sensitive images, you could see some very bright signal around the left hip. This told us that there was fluid on the left hip. This child had a left hip effusion. And when we actually read into her history, we learned that she had had a fever about a week ago. She had been having some hip pain, and she had a history of sinusitis, which had been treated recently. No known history of stress. So this child went home, then came back a week later. A week later, we did an ultrasound, and you can see an ultrasound of both hips here, the right hip and the left hip. The way that this ultrasound is being done is, imagine that this is the ultrasound probe. We're taking the ultrasound probe and put it directly onto the patient's hip in a sagittal direction. So this would be facing the patient's hip. The patient's head is to our left, and the patient's feet are to our right. And what you can see here are some calipers on the ultrasound. You can see on the right hip there's some calipers measuring something which is very low echogenicity or dark, and something also on the left. This is fluid now in both of the patient's hips. Before, recall, we only had fluid in the patient's left hip, and now we have fluid in both of the patient's hips. Ultrasound is very good for detecting joint effusions, particularly in the hip, particularly in children, because you don't have the problems with obesity that sometimes you have in an adult population. So this was confusing. The child came in, had pain on the left hip, now was having pain a week or so later in the right hip. We did another MRI, and you can see a difference. And so again, this is the fluid-sensitive imaging all the way to our left, and the T1 weighted imaging all the way to the right. We can see on the fluid-sensitive imaging that there's now fluid on both hips, more now on the right side and less on the left side. And for those of you who are confused, I'll remind you that when we look at coronal imaging in a patient with MRI or CT, it's as if though the patient is facing towards us. So the right is to our left and the left is to our right. So now we see fluid in both hips. The question is, what type of entity would create fluid in both hips after a febrile illness in a patient within a week or two of each other? And the answer is transient synovitis or toxic synovitis. Toxic synovitis or transient synovitis occurs in children. It's very frequently seen. It's a frequent cause of hip pain for children, and it typically resolves with without any long-term sequela, given kind of some expectant symptomatic treatment. We're going to move on, however, to the twin sister of transient synovitis, which is a much more serious condition, and this is where the diagnostic dilemma often lies. The next case we're going to look at is a 16-month-old boy with left hip pain. Now here we're also doing radiographs. You can see an AP view and frog leg views of the hips and pelvis, but this time it's not as normal or as unremarkable as the previous set of x-rays. One thing that you can notice is that there's a lot more distance between the femoral head and the acetabulum on the patient's left than there is on the right. That, particularly in a child, concerns us for a large effusion or a large amount of fluid on the hip. There's also what looks like some heterotopic ossification adjacent to the patient's left femur. This child also had an MRI. So in this MRI, we're looking at a combination of fluid-sensitive sequencing and images and also contrast-enhanced images. You can see that this is much more abnormal than the previous exam. And I'm going to point out a couple of findings. First, let's look at the normal right hip. There's a trace amount of fluid in that hip, that little bit of bright signal. And that amount is normal. You can also see the fluid in the patient's bladder here. But there's so much edema and fluid in and around the patient's left hip, in the soft tissues, within the joint, and even within the bone itself. This is not transient synovitis or toxic synovitis. This is septic arthritis. And septic arthritis is potentially much more serious than transient synovitis. Let's take a look at how serious it could be. Here's an example or a case of septic arthritis from the bad old days that shows the radiographic evolution of this finding. So on this admission x-ray, you can see that there may have been some widening of the left hip compared to the right. As time went on, 3 days later, there's ongoing widening of the left hip. 3 weeks later, you can see that there's a lot of space here, and now there's been significant changes in the bone. So this is not only septic arthritis, but also osteomyelitis. You can see significant periosteo elevation, some sclerosis of the bone. There may also be some lucency there. 7 weeks later, you can see that there's been quite an amount of abnormality in the left hip and left femur. So this is septic arthritis that led to a chronic and poorly controlled osteomyelitis. So septic arthritis, osteomyelitis can be quite serious. It's important for us to detect, and it's important for us to be able to differentiate, depending on our clinical concern and the imaging, between transient synovitis and septic arthritis. We're going to move on to another case. This is an 11-year-old boy with left-sided hip pain. What we have is a radiograph to our right, and we have T1 and T2 fat-saturated MR sequences on our left. And if you just look for asymmetry, some of you will be able to pick out exactly what is going on here. So if you look at the right hip on the x-ray, you can see that the femoral head, the epiphysis, is almost like an ice cream cone, or like a scoop of ice cream sitting on an ice cream cone. If you look at the affected side, it almost looks like that scoop of ice cream is falling off. And there is an abnormal alignment between the femoral neck and the femoral epiphysis or femoral head. If you look at the MRI, you can see the growth plate on the normal side is as this black line, or as this faintly low signal and high signal line on the T2 weighted images. However, on the affected side, that line is much more irregular. The growth plate is widened. If we look at the fluid sensitive images, we can see that there is a greater amount of abnormality and greater amount of signal at that growth plate. This entity, which is common in young boys, typically from 10 to about 17 years of age, is slipped capital femoral epiphysis, or SCFE. And in this type of situation, there's actually a Salter type 1 slip injury between the femoral neck and the femoral epiphysis. If this is caught on time, and if the patient is thought to be at risk for further slippage at the growth plate, then an orthopedist can be consulted, and if it's thought appropriate, they can actually pin the affected side and potentially even the unaffected side if they believe that it's at risk for further abnormality. So SCFE. Next case, another young boy, an 11-year-old, this time with right-sided hip pain. So look at this X-ray, and you'll be able to see that the normal left-sided femur and femoral neck, nice and round, well seated within the acetabulum. On the right side, the affected side, you can see that there's an abnormality of contour of the right femoral head. The right femoral head is flattened. It may have some extra sclerosis. It doesn't contour well with the acetabulum at the same point. So this is an abnormality which is also seen in young boys. It could be young boys or girls. If we look at MRI, you can get a better idea of what's going on here. So here we have a T1 weighted image, a fluid sensitive image, post-contrast imaging, and subtraction imaging. And the asymmetry here, you can see, is that the femoral epiphysis, the femoral head on the right side, has all this abnormal low signal. And the fluid sensitive images, it's also abnormally low in signal. When we give contrast, we see that it doesn't enhance. And when we do subtraction images, we can see the normal side has a certain amount of normal signal, but the right femoral head is really low signal, very, very dark. So this is Perthes disease. Perthes disease affects children, and it can be typically unilateral, and it can cause pain. We can see Perthes on radiographs. It's not evaluated with ultrasound. However, if we choose to do an MRI, some orthopedists, especially with contrast enhancement and subtraction imaging, we know that we can better prognosticate what's going to happen to this femoral head in the future and what is a likelihood and risk of further collapses. So we're concentrating, just to recap, on all types of things that can affect the hip, causes of hip pain. So far we've talked about transient synovitis, septic arthritis. It's important to differentiate those two because one is not very dangerous without a lot of long-term sequela, but one can have a very significant long-term sequela. We've also talked about SCFE, or slip capital femoral epiphyses, and now we've talked about Perthes. Sometimes children think that they're having pain in the hip, and they'll point to the area of the hip, but they haven't had anatomy courses yet. And it can be difficult for us to tell what is the femoral head, what's the acetabulum, and what is affecting the regional area as well. This is a 16-year-old boy who complained of hip pain. When we did an MRI, you can see that we have fluid-sensitive imaging here, T1 weighted imaging here in the axial plane, and then we have coronal T2 weighted imaging here, you can see the asymmetry. There was a lot of increased signal in the right iliac wing adjacent to the sacroiliac joint. This child had this type of iliitis, and we were concerned for sacroiliitis. However, there was some concern that the child may have had something else. Now, ordinarily, we would not do a biopsy of this entity, but for whatever reason, this child ended up getting a biopsy. There was a concern for some greater abnormality, but this ended up being, this child had inflammatory bowel disease, and this ended up being inflammatory bowel disease related sacroiliitis. So sacroiliitis will sometimes, we'll often lump it in with hip pain, although anatomically it's in a different region. We can detect sacroiliitis with the experienced clinician from physical examination and from radiographs, but the most sensitive imaging modality is certainly MRI. In the US, we have a lot of MRI, which is good and bad. In this case, it's good that we can diagnose these types of findings with imaging, which is readily available. On the other hand, sometimes it hurts the clinical skills of clinicians who are more prone to just ordering imaging than to be able to practice their physical examination skills. If you have any questions, feel free to type them in as we go along, but we'll certainly have some time for questions at the end as well. We're moving from the hip down to the femur. And what we'll do is as we go more distally, we'll look at more and more cases. So this is a case of a 9-year-old boy who had right-sided leg pain. We knew that it was localized to the right femur because at 9 years of age, a child can tell you where it hurts. We did a radiograph, and it's possible that some very astute radiologist would have been able to pick something up here. But for most people, this is an unremarkable radiograph. However, when the child came back 2.5 weeks later and was imaged again, we can start to see some abnormalities on this radiograph, and I'm going to point them out for you. One thing that we can see is that there's too much soft tissue anterior to femur here. This child has a joint effusion. The other thing we can see is that there's some very subtle sclerosis and maybe even a little focal area of lucency in the patient's distal femur. So there's this heterogeneous sclerosis and alternating areas of lucency in the patient's femur on the radiograph. When this child had an MRI, we were able to see some very important findings. We see on the fluid-sensitive images that there's edema in the distal femur. So you can remember edema or fluid on these T2 weighted images are going to be bright. On the sagittal images, you can see some joint fluid. You can also see quite a bit of edema and fluid in the musculature surrounding the femur. When we gave contrast, the most important finding was that most of the femur was enhancing. However, there was a focal area, a spot within the distal femur that wasn't enhancing. This is osteomyelitis developing Brody abscess. So again, infection can occur and start within the joint, but it can also occur within any long bone as well, separate from a joint. It's important for us to detect osteomyelitis because typically these children will get intravenous antibiotics for quite some time if they're capable of getting that treatment. Now, the difficulty with younger children and osteomyelitis is they can't tell you where it hurts. This particular child's case that we looked at was a little bit older, and they could say, I have symptoms in my distal femur. But what if they're 3 years old or 2 years old and they're just limping and you're worried about an infection? Well, certainly radiographs are an important first point of imaging investigation. If you are concerned about the hip, then a hip ultrasound would be very appropriate. If we do MRIs of the lower extremity to figure out whether there's infection in a younger child, we have an algorithm that helps us hone in on the appropriate location. So we start with very large field of view, fluid-sensitive imaging, and some other sequences. If there are no findings, then we know that it's normal. If there are findings, we decide whether to give contrast or not. In most cases, we end up giving intravenous contrast. Intravenous contrast will help us determine whether there's soft tissue abscess, whether there's a Brody abscess, and then we can determine whether it's osteomyelitis that's complicated or uncomplicated. So here's an example of how this type of algorithm would work. In this large field of view, T2 or STIR coronal views of a child, we can see that everything is nice and low signal along the right, from the right hip all the way down, almost to the right ankle. And as we look at the left side and we go up, we can see everything is nice and low signal as it should be, until we get to the left acetabulum, where you can see some asymmetry. There's increased signal in the left acetabulum. When we do further imaging, we can see that there is quite a bit of abnormal signal in the left acetabulum. And so this child had, this was how we could diagnose this child's left-sided osteomyelitis. In the distal femur, here's a child who is 13 years old, had left-sided knee pain. And you can see on the radiograph that there's an abnormality of some irregular lucency centered at the distal metaphysis right up against that physis laterally. This 13-year-old boy with left-sided knee pain was thought to have osteomyelitis. At some point, we did an MRI, and you can see the findings are abnormal also on the T1 weighted imaging and the T2 weighted imaging as well. But this child didn't have osteomyelitis. They actually ended up coming back later on, several months later after their knee pain resolved, with pain of a very similar nature in a different body part. This is an entity which we call CRMO, or chronic recurrent multifocal osteomyelitis. It also is called CNO, or a chronic non-bacterial osteomyelitis. It is not an infection, but it acts like an infection. And oftentimes these patients are misdiagnosed with having osteomyelitis unless there's a suspicion for having CRMO. And one analogy that's been used is that this is almost treated like multiple sclerosis of the bone. There are areas of involvement at different times and different locations that come and go. And rheumatologists are often, particularly pediatric rheumatologists, are often very good at making the diagnosis of chronic recurrent multifocal osteomyelitis, but they rely very, very heavily on an imaging approach as well to determine where the areas of abnormality are. We're going to stay with the femur for a little bit. There are some subtle findings on these radiographs. I hope that through the internet and through the shared meeting online that you're able to see them, but I'll point them out. These findings are some of the most important findings that we can make, can really be a life-changing finding in any child's life. The findings here we're going to talk about are imaging focused, but of course a clinician, even without imaging, could have a suspicion for this diagnosis. So this was a young child who came in, wasn't moving their legs appropriately. You can see we have imaging of the right side and the left side. If you pay very close attention, you can see that there's a thin stripe that's high density running along the femoral shaft on both sides. That is periosteal elevation. If you pay attention to the distal femur, you can see that there's a little bit of irregularity right here. The distal femur, there's also a similar finding of the metaphysis on the other side. These are classic findings for non-accidental trauma or child abuse. The mechanism in these very young children, typically infants or younger than 2 or 3 years old, is a shaking mechanism of the child. And when that child is shook back and forth violently, the bones experience a shearing injury at the growth plate and at the physis. And that growth plate and that femur, the femur is not meant to withstand that type of shearing at that time. And that's what leads to what we call these classic metaphyseal lesions. They're also called corner fractures or bucket handle fractures, depending on how you catch them. If you pay very close attention to this case, you can actually see that the technologist who was helping take the x-ray covered with his or her finger an actual fracture of the right tibia. So there was a more significant fracture of the right tibia here, along with the other findings this made it a very clear-cut case of non-accidental trauma or child abuse, which is always important for us to have a high suspicion for. It certainly occurs in every population. We're going to talk now about this 7-year-old girl who came in with a painful leg. We didn't know why she was having a pain in her distal left femur, her distal left thigh. If you pay very close attention to these x-rays, you can see that there is a finding right here. And this finding is periosteal elevation. It seems very smooth, but it is actually very classic for an aggressive type of periosteal elevation. As we did more workup of this 7-year-old girl, we did an MRI, and we could see that there was a soft tissue mass in and around her distal left femur. You could see it was replacing the normal bright signal of her marrow on the left femur, and there was quite a bit of edema in the adjacent soft tissues. The only sign on the x-ray was this periosteal elevation. This was osteosarcoma. So it is not unusual for young people, children and adolescents to be affected with sarcomas of the soft tissues or bone. They're not common, but they do occur and they need to be in our differential. Osteosarcoma, Ewing sarcoma, both can occur in the lower extremities along with other sarcomas as well. It's very important for us to pay close attention to, was there trauma? Are we concerned for infection? If neither is the case, then we have to consider neoplasm on our differential as well. And in this case, it was diagnosed by a combination of astute clinical examination, but also the imaging. This is a child, a young child, who was imaged 3 months apart in July of 2010 and then October of 2010. These are fluid-sensitive images. Now, these images aren't flipped. The left femur and thigh is significantly involved in July, and then the right femur and thigh is significantly involved in October. This child also has abnormal signal throughout the marrow. Ordinarily, marrow would be nice and dark on a fluid-sensitive sequence that's fat-suppressed because of the fat that's within the marrow. So what entity could create this type of gross abnormality 3 months ago on one side, 3 months later on the different side? This was sickle cell disease, and the child was experiencing acute sickle cell crisis and infarcts at the time of imaging in July and then in October. So sickle cell disease can be a significant cause of pain and limp. Of course, it's not limited to bones of the lower extremity, but something to consider in our differential. We're moving down. Initially, we started with hip. Then we talked about quite a differential in the femur, and now we're talking about entities that can occur in the knee. And then we'll go quickly through tibia, foot, and ankle so that we have some time for questions. This is a child, an 11-year-old boy who was injured when he fell off a bike. And you can see that there is a fragment of bone here along the expected course of the patellar tendon. This is a patellar sleeve avulsion fracture. The mechanism for this is typically an avulsion from the inferior pole of the patella. And sometimes, if there's quite a bit of cartilage, we may only see a small sliver of the osseous portion of the patella, which is our tip of the iceberg to key us into the fact that there's actually an injury here. So an avulsion of the knee that's typically seen in children, a patellar sleeve avulsion fracture. Here it is on MRI, or a different case on an MRI. You can see a low signal crescent here, right over here as well, that's come off the lower pole or the inferior pole of the patella. Again, an avulsion from the patellar tendon pulling off a portion of the patella related to trauma. Now, a lesser injury, but a more chronic repetitive injury would be the type of edema that you see of the inferior pole of the patella here, and also in Hoffa's fat pad, just posterior to the patellar tendon. This is jumper's knee, and this is from often from children that are very active. They can have a chronic type of repetitive stress injury at the patellar tendon origin with the inferior pole of the patella. And so you see edema there that's abnormal and some irregularity as well. This is jumper's knee. Now, one thing that we'll see in young children that have knee pain, it's an entity that can occur elsewhere as well in the talus or other parts of the body. Sometimes this entity that's called, that you can see over here. So you can actually see that there's an irregularity of the articular surface. We have a T1 weighted image to our left. These are coronal images of the knee. And we have a T2 weighted image to our right. Just for orientation, we're looking at the femur here, the tibia here, and the fibula here. The patient is facing up. This is the patient's right knee. And you can see that there is an abnormality, an area of low signal on T1 weighted images, very focal, and the lateral femoral condyle on the T1 weighted images. It corresponds to some bright signal in the lateral femoral condyle on the T2 weighted images. This is osteochondritis dissecans, which can cause pain in any child's knee or other joints. And in this case, actually, there may be already a loose body within the joint, which is one of the risks with osteochondritis dissecans. Another entity that can affect the knee, in this case, we have a child who is experiencing more long-term pain in her knee. We have an ultrasound and we have an MRI. We can see enhancement of the synovium and some thickening of the synovium in this child's knee. We also saw some thickening of the synovium on the ultrasound, and it was probably seen better on the real-time ultrasound, but there was some hyperemia of the knee as well. This is a case of juvenile idiopathic arthritis. Juvenile idiopathic arthritis, as you know, can affect different joints. It's different than rheumatoid arthritis as seen in adults. And depending on which organization criteria you may ascribe to, whether it's the International League of Associations for Rheumatology, the European League Against Rheumatism, or the American College of Rheumatology, there are different criteria for the diagnosis of juvenile idiopathic arthritis. Findings that we see eventually are periosteitis, joint space narrowing, erosions, but things that we see in juvenile idiopathic arthritis that you don't typically see in adult rheumatoid arthritis, because of chronic hyperemia, you can see near a growth plate that's still growing, and that's not closed yet. You may see growth disturbances. Sometimes there can be premature physeal fusion, so there could be actually a short limb, or you can have chronic hyperemia can actually lead to overgrowth as well. And it's very common for us to see joint diffusion. In extreme cases, there can actually be ankylosis or at the joint as well. Radiographs in early arthritis are not that helpful, but they are a very common examination for us to do for imaging of juvenile idiopathic arthritis to determine chronicity and also to determine course. An MRI can help with determining whether there's inflamed synovium, cartilage destruction, bone erosion, and other changes such as meniscal hypoplasia in the knee. Ultrasound is very sensitive for pannus. It can also be very sensitive for thickening and enhancement of synovium. Nuclear medicine has a limited role, but interventional procedures, imaging-based procedures can have a role, particularly for steroid injections in joints which are otherwise difficult to access without imaging. This child had a known diagnosis, and on these x-rays of the knee, you can see a lot of irregularity of the joint space, some erosion of the tibial plateau. There also may be a joint effusion. When we did an MRI, we could see a lot of low signal material within the joint space on the T1 and the T2 weighted images, and you can see some chronic changes within the bone. On gradient echo images, we can see a lot of what we call blooming. Blooming occurs when we have blood on an MRI. So this is a case of hemophilia. This child was bleeding into his knee. and over time had chronic changes. This is a case of a discoid meniscus. Children with a chronic knee pain, and sometimes they'll have a specific joint line tenderness laterally. With an MRI, we can diagnose a discoid meniscus, which is an abnormality anatomically of the meniscus that typically will require resection. Otherwise, it will lead to long-term pain in that child. On this X-ray of the tibia, you can see some lucencies in the distal tibia, here on the lateral and here on the AP views. This is a typical toddler's fracture. Young toddlers, as they're learning to walk, can have this type of fracture. It's very important for us to pay close attention, and that's why radiographs are usually the first line imaging. And this 14-year-old boy with shin pain, you can see a little bit of sclerosis. On the MRI, you can better see that this child had a stress fracture, probably from running too much. Pain after fall in a 13-year-old boy. We're moving down to the foot and the ankle, and we're coming to our conclusion. You can see some lucency in the growth plate, or the epiphysis, rather, of the distal tibia, but also involving the metaphysis. This was a triplane fracture, which is better characterized by CT. Triplane fractures are something which are unique to children in the distal tibia because of their open growth plates. There's also a variant which is called a juvenile to low, which occurs because of the way that the growth plate closes, where the anterior talofibular ligament can actually avulse a portion of the distal tibia. So these are fractures which are unique to children, which can be seen on radiographs, but can be better characterized by CT if necessary. And here's the mechanism for the juvenile to low. And then polyarticular juvenile idiopathic arthritis, you can see on the X-ray and the MRI, there's quite a bit of an enhancement in this child, in this 5-year-old boy's feet. A lot of abnormal enhancement of the synovium and of the talus, and also of the midfoot. So this was juvenile idiopathic arthritis that we had seen a case of before as well. Here's an example of overgrowth that juvenile idiopathic arthritis can cause. You can see that how long that fibula is with respect to the talus. Ordinarily, the fibula would be shorter here, but the chronic hyperemia can lead to these types of growth disturbances. And we can always do image-guided procedures where we can deliver steroid directly into a joint if that's determined necessary by the pediatric rheumatologist or for the clinicians or pediatricians that are taking care of the child. Particularly with TMJ joints or hard-to-reach joints if there's monoarticular arthritis, or if they don't want to go up on their systemic treatment, this can be a good option. So in conclusion, we've talked about different causes of pain in the lower extremity in a child. We went from the hip to the femur, to the knee, to the lower leg and the ankle and the foot. And these are the cases, the diagnoses that we were exposed to during this talk. Transient synovitis, septic arthritis, very important for us to be able to differentiate. Other things that affect pediatric hips. We used the femur as an example of complicated osteomyelitis, non-accidental trauma, or child abuse. We also talked about some cases of tumors such as osteosarcoma. Neuroblastoma can be metastatic to the femur or other bones as well. We talked about sickle cell disease. We talked about some types of trauma which are specific to children, such as patellar sleeve avulsion, toddler fractures, and triplane fractures in juvenile to low. And of course, we mentioned juvenile idiopathic arthritis. I really want to thank you all for your attention, and I'm happy to take questions if there are any.
Dr. Safdar?
Yes.
Good morning. This is Fuad. I have a small question. When do we usually order an X-ray at the beginning.
Mm-hmm.
When would you consider ordering an MRI? Is it when we find nothing on the X-ray, or is it if you find something on the X-ray, or because it's kind of a trouble when it comes to cost in some countries, you know?
Right. Well, so typically an X-ray would always be done first. And I understand that, you know, in the U.S., MRI is probably overutilized compared to other locations. So I can speak to what the typical practice is here. And typically here, after initially doing the physical examination and an x-ray, if the x-ray is negative, it really depends on a matrix of your level of suspicion for infection or for something else bad that's going on. But if the concern was trauma, and we're really worried about this child having an injury, if the x-ray is negative, typically there's not much more reason to do an MRI. Because you're looking for a fracture, x-ray or radiographs are sensitive for fracture, so if you don't find something, then it's okay to not work it up any further. However, if they have a fever, or if they have other systemic symptoms, and it's not just the hip, because if it's just the hip, an ultrasound is very good for determining whether there's a joint effusion or not. But if there's a long bone, such as the femur or the tibia involved, if there's a fever, if there was no antecedent trauma, then an MRI becomes more appropriate, especially if there's swelling or erythema or other signs of possible infection or neoplasm, because in those cases it can be important for us to figure out exactly what's going on and get that child appropriate treatment sooner rather than later. Now, in some cases, if they've had sepsis or some kind of known infection, systemic infection, it may be appropriate to treat for osteomyelitis or bone infection or septic arthritis empirically, especially if getting an MRI will delay the treatment. But if MRI is available, then it's reasonable to do that as well. Does that make sense? Does that answer your question?
Yes. Thank you.
And I want to point everybody to, there's an ACR, American College of Radiology, appropriateness criteria, which publishes guidelines about the limping child and the painful lower extremity and the imaging workup for it. And that document is available online, and it has very good resources. It currently lays out a lot of this approach, and there will be a future revision probably coming out shortly that goes into more detail.
Thank you, Dr. Safdar. Just can you give us some resources that for students and residents to use to review these things regarding imaging pediatric patients that we could utilize during our studying and during our residency? Some of the resources you recommend.
Sure. So I think probably one of the best resources is the appropriateness criteria provided by the American College of Radiology. The guideline that they have, which is entitled Limping Child, ages 0 to 5 years age. I have it up on the screen here. There are other great resources as well. And if you bear with me 1 minute, I can actually share with you some general pediatric imaging websites. And I could send those to you, and you could perhaps share them with the students and residents or others that would be interested in going to those websites. There's some free websites that have very good curated content, and they're often what we recommend. They even have some tests associated with it. One of them is the Pediatric Radiology site, which is curated by the Cleveland Clinic. So if you Google Cleveland Clinic Pediatric Radiology, you can actually sign in. They have an image gallery, but they also have a nice curriculum there, which contains many of the core competencies for residents or for medical students.
Thank you very much. Do we have any question from any other sites? You could either type the question or you could unmute your mic and ask the question. I guess thank you very much, Dr. Safdar, for this very helpful presentation. We will have this presentation recorded and posted on our site for people to review and look at. And if you have any resource to share with us, please feel free to email us about it, and we will share it with the group and our mailing list. Thank you very much.
Thank you. It was my pleasure.
Thank you. Thank you. Thank you, everyone, and have a great day.